Good afternoon, everybody, and welcome back, and welcome to those who didn't join us this morning. We've had a fantastic morning. I think around 800 people arrived, and we've had tons of questions and tons of interaction, so I'm really pleased. We're going to be pretty smart on the timings this afternoon, so with no more ado, I'm going to introduce the first clip, which is we heard from people this morning about why screening is important and what makes it hard for them to join. So we're now going to hear from the same group of people about what makes screening easier for them. Thank you.
Yeah, and I normally see the learning disability nurse, and I go, and I always make sure it's a female nurse to make you feel more comfortable with it. I normally feel brave enough to go alone, or as sometimes could go with my mum as an option if I wanted to. I normally get a reminder from the doctor's surgery for when I need to go to my screening appointment. They always explain everything about the procedure when I get there, and there's a little summary of it afterwards. They always give me little coping methods as well, so like taking deep breaths throughout the procedure as well. I would normally say that for me, having Down syndrome, I know it's important for me to know what's happening, because I always like things being explained properly to me all the time.
By having the same family as a doctor and before you go for your appointment, ask if you can have a look at the equipment. And then the doctor and nurses have to be caring and understanding.
Cervical smear can be quite painful for some people. It's very, very helpful if you've got an understanding doctor or nurse who understands that, especially for someone with a learning disability.
I would say that they need someone to explain to them simply and easily so they can understand. I think it's by sending them a easy accessible information sheet with the time on it, the picture of the person they'll be seeing, and also mention if they'll be seeing a learning disability nurse, or when I also ask you if you've got to bring an advocate or a support worker with you to your appointment. These citation visits can help by if the person that comes and sees you, whether it's a health nurse or a clinic nurse comes and sees you, brings you an easy accessible sheet which tells you what's going to involve the treatment, so you can be able to understand, go through it with you, help you to read it if you can't understand it, listen to your worries and concerns, and try and be sympathetic.
What I would think would be to make information in easy read, let their staff have learner disability awareness and sincerity. If you can't do something, don't say you can do it. Their best bet is to be honest from the start.
That it is really important that an advocate can go with you, so they can support you while you're at the doctor's surgery, not going on your own to be too nervous.
Thank you very much. I think they might be my favourite part of the conference. These video clips. It really brings it to life for me. So I'd like to now introduce my next speaker, Professor Pauline Heslop, Professor of Intellectual Disability Studies at the University of Bristol. and Programme Lead of the Learning Disabilities Mortality Review. We heard some of the data in Sheila Holland's presentation this morning, and she'll now tell us about some of the data and evidence about screening people with learning disabilities. Thank you.
Thank you, and thanks very much for inviting me here today. So in this presentation, I'm going to summarise the evidence we have about screening for people with learning disabilities. So slide 1, please. As a reminder, let's start out with setting out the expectation. And I just want to remind you about 3 key pieces of legislation and policy that are important in this respect. The first is the Equality Act 2010, which certainly Sheila Holland mentioned this morning, and a number of other speakers. And that requires public bodies to make reasonable adjustments to ensure that people with learning disabilities can use their service. The second I want to remind you about is the Health and Social Care Act 2012, and that makes it a legal duty for public authorities to have regard to the need to reduce inequality in the benefits that people in England can obtain from the health service. The third is Public Health England's own screening inequality strategy, which was updated in 2020, which seeks to address the, and I quote, unwanted and unfair barriers that may mean people do not engage with an offer of or participate in screening, or who are disadvantaged in maximising the benefits of screening. So that's the end of the quote. And we know that screening inequalities can occur at any point along the screening pathway, from the provision of information about screening, as we've heard this morning, to accessing screening services, and also to onward referral if needed. And those inequalities can be at national level, they can be at regional or local levels, and we've all got a part to play in ensuring that those are reduced. So to determine if people are receiving an equitable service, we need data. And this slide shows what we know about recent screening rates in England. So the best data that we have is that held by NHS Digital, and it's published as part of their experimental statistics each year. Now, it only covers breast, colorectal and cervical cancer screening. I'm a researcher and I've been unable to obtain national data for any of the other types of screening for people specifically with learning disabilities. It may be that it's out there, it's just I haven't been able to find it, I'm sorry. And the data here only relates to England, and it's based on approximately half of patients registered with GPs in England. So there will be some CCGs that have no data contained within this data set. And the graph here shows screening rates for people with learning disabilities against people without learning disabilities in each of these 3 screening programmes. And you can see that people with learning disabilities, represented by the solid blue bars, have much lower screening rates than people without learning disabilities, which are in the patterned bars. So let's look at this a little bit more closely. The next slide, please. So for breast cancer screening, there was a 15% difference between people with learning disabilities compared to women without learning disabilities in England. So in 2018-19, 49% of women with learning disabilities received screening, and that was compared to 64% of women without learning disabilities. Now, somewhat worryingly, between 2014-15 and 18-19, there's been a slight decrease in coverage of breast cancer screening in people with learning disabilities, and it's reduced from 52% to 49% during that time. So the next slide, please. For colorectal cancer, there was a difference of just 4% between people with learning disabilities compared to people without learning disabilities in England. Between 2014-15 and 2018-19, learning disability coverage improved substantially from 69% to 83%, which has brought the rate right up to almost the same as in the population of people without learning disabilities. The next slide, please. The difference between women with learning disabilities and women with cervical cancer is the most marked. For cervical cancer, there's screening, there's a 41% difference between women with learning disabilities and women without learning disabilities. So in 2018-19, 34% of women with learning disabilities received cervical cancer screening, compared to 75% of women without learning disabilities. And if you were looking at this over time, between 2014 and 15 and 2018-19, learning disability coverage has improved, but only very slightly, so from 30% to 34%. Next slide, please. Now, another potential source of information about cancer screening rates is the Learning Disability Mortality Review Programme. We call it the LEADER programme for short, and I'm the programme manager based at the University of Bristol. Now, the LEADER programme supports local areas to review the deaths of all people with learning disabilities aged 4 years and over, and data from completed reviews is collated and analysed nationally. Now, this data relates to people who've died, so that may or may not affect screening rates, of course, and particularly if people are on, for example, an end-of-life care pathway and screening is no longer felt to be appropriate. So we're not comparing like with like here. Now, the question that LEADER reviewers ask when conducting a review into a person's death is, had the person received age and gender appropriate health screening? And then the reviewers provide more detail about this. However, the data from the LEADER reviews is somewhat problematic in that reviewers are often unable to identify whether age-appropriate screening has taken place. And for about half, 45% or 50% of cases, the data is either missing or it's not known, reinforcing, arguments that data collection and availability about screening does need to be improved. So, excluding the missing or unknown data, the proportions receiving breast, colorectal or cervical cancer screening is noted here. So we had 52% of women had received breast cancer screening, 78% of all people had received colorectal cancer screening, and 31% had received cervical cancer screening, and that's of eligible people. The next slide, please. So this slide I've just brought together comparing the difference between NHS digital data in the dark blue bars, in the hatched bars, with the LEADER data in the dark blue bars. And you can see that they're broadly similar, giving us some confidence about the accuracy of the data that we do have. The next slide, please. Now, we've also looked at the literature about barriers to screening in people with learning disabilities and what the research evidence says about this. And I would like to acknowledge the work of Jo Wood from Public Health England here. She works in the Knowledge and Library Service, and she conducted a literature search for any evidence or data relating to the uptake and access of NHS screening programmes for people with learning disabilities. And her work has been invaluable in helping me draw this together, so thank you, Jo. And the literature only really explores breast and cervical screening. Again, we know very little about the other screening programmes. So in terms of breast cancer screening, which is on the slide presenting here, you'll see I've listed some of the barriers or potential barriers here, and the references that are beside them are included in the final 2 slides of this presentation. Now, many of these barriers, as I'm sure you can see, are things that we can do something about, and many of the presentations today have been emphasising aspects of these and local areas taking action to address them. So the systems issues include issues relating to informed consent and vulnerability being promoted, particularly in people with learning disabilities, and practical barriers such as transport and timing of appointments. There's also issues related to care provision, limited knowledge of paid carers, staff attitudes, communication issues, a lack of training in cancer prevention, and paid carers sometimes being unaware of family histories and so not being as responsive maybe as they should be. And then in relation to people with learning disabilities, inadequate knowledge, embarrassment, fear and anxiety is reported in a lot of studies, that women in particular don't check their breasts regularly or know what they're looking for, and that sometimes they can be put off by previous experiences of mammography or of hospital stays, and that affects whether they will turn up again for screening. The next slide, please. This slide summarises some of the barriers we know to uptake of cervical screening. Again, there are some barriers for women themselves, such as limited health literacy, but there are many barriers that are related to systems issues and the provision of care, all of which we could do something about. So in terms of systems issues, there's issues about eligibility, informed consent, vulnerability. There are practical barriers. So for example, time pressures. It takes more time to explain to a person with learning disabilities. Sometimes inadequate resources and invitation letters, and sometimes the call and recall system can be problematic for people with learning disabilities. In terms of care provision, research evidence suggests that there are a number of barriers here, including assumptions that people are not sexually active, and Sheila Hollins spoke about that this morning. The negative attitudes of some paid carers, limited knowledge of some paid carers, and often competing demands on paid carers. The limited exposure to people with learning disabilities by some health professionals, and a lack of appropriate knowledge, attitudes and skills, which we've also heard about this morning. The next slide, please. So finally, let's look at some of the strategies that we can use to improve screening rates for people with learning disabilities. Essentially, research evidence suggests that we can help by preparing people psychologically for screening to enhance their understanding, to increase predictability and to minimise anxiety. We can optimise people's experiences, and that does relate to whether they will return or not. We need to take an interdisciplinary approach to work across care sectors, and crucially we need to be working with people with learning disabilities and their families in all aspects of their care. So in conclusions, there are large gaps in our knowledge about rates of screening for people with learning disabilities. Our most complete data is for breast, colorectal and cervical cancer screening, but it does only cover about half of patients registered in England. And data suggests that disparities with people with learning disabilities and those without learning disabilities. And the largest disparity is for cervical cancer screening. Breast cancer screening has been decreasing slightly since 2014-15, which is of concern. But the good news is that colorectal cancer screening has been improving. It's now approaching that of people without learning disabilities, and many of the barriers that research evidence identifies are remediable. Strategies to improve uptake should include working with people, their families and the paid carers to optimise their experiences and ensure they're well prepared. Thank you.
Sorry, God, button crisis. Thank you very much indeed, Pauline. That was extremely helpful. The colorectal thing was quite surprising, I thought, actually. I was quite surprised and cheered by that. So thank you very much indeed. I'd like to now move on to introduce Katie Robb, who is a reader in behavioural science and health at the University of Glasgow, and she'll now present on research in Glasgow on access to cancer screening amongst people with learning disabilities. Thank you.
Good afternoon. Thank you so much. I'm Dr. Katie Robb, and I'm delighted to have been invited to speak to you today. So I'm speaking to you from rainy Glasgow, where we're in the midst of lockdown, and one of the perks of working from home, I've just discovered, is that you can be passed a beautiful, I don't know if you can see that, good luck card that's just been hand painted for you. So that's cheered me up before I give my presentation. So next slide, please. evidence. So I'm a researcher and I like evidence of what the problem is, which has been very well spelled out this morning already and by Pauline, and what the solutions might be. So cancer screening can save lives if the people invited participate, but there are stark inequalities in uptake, and our current one-size-fits-all approach to screening invitations is failing to sufficiently engage the most vulnerable. Evidence on access to cancer screening for people with intellectual disabilities remains really under-researched and piecemeal. And cancer research among people with intellectual disabilities and other vulnerable groups is neglected and underfunded, and we need greater diversity in our approach as a research community. Within the UK, there is some excellent local activity, as we've heard about today, but this is not always captured in the published literature, so we're not aware of what work is being done and where. And there's little to inform an evidence-based national approach. There's an urgent need for a stronger evidence base and a more precise and targeted approach to supporting our most vulnerable in society to access cancer screening and benefit from the earlier diagnosis of cancer. Next slide, please. So cancer screening has been the focus of my research for almost 20 years now, and I'd like to tell you a little bit about our research and how we came to be involved in research with people with intellectual disabilities. So our story starts with this observation of uptake overall in the Scottish population, and a simple question: why does bowel screening fail to achieve the uptake rates of breast and cervical screening? We think about inequalities within screening programmes, but we can also have inequalities between programmes. Next slide, please. And as a behavioural scientist, it's interesting to consider why the same women who value the benefits of cancer screening and the earlier diagnosis of cancer are willing to complete a test for breast and cervical, but not bowel. So this led us on to our research. Next slide, please. And if you just click all the way through them. So in Scotland, we invite, because we've got a younger starting age for bowel screening, we have this situation where women between the age of 50 and 64 are invited for all 3 screening programmes. So we felt this was a good opportunity to understand why there may be differences in patterns of screening behaviour. Next slide, please. So with funding from the National Awareness and Early Diagnosis initiative, I co-led a piece of work with Professor Colin McCowan and Dr. Marie Coetzer, who led on the qualitative work, which I'm not going to go into today. But with the quantitative work with Colin, next slide please, we were able to link together data from the 3 bowel screening programmes, which was sort of a feat in itself to even achieve that. We then added in data from prescribing data on use of antidepressants, because we were particularly interested to look at the impact of mental health on screening uptake. And then from GP data, we were able to get information on comorbidity and learning disability. And this was my first experience of working with learning disability data. Okay. Next slide, please. So we had data for the whole of Greater and Glasgow Clyde NHS for women who had been invited for screening during 2009 and 2013. And what we found was we had highest levels of uptake was for cervical at 81%, followed by breast at 73%, and lagging behind as expected was bowel screening at 62%. Now, only 52% of women were participating in all 3, which is quite disappointing, really, that only half are taking up this offer. And 7.2% were participating in no screening at all. Next slide, please. So across all 3 screening programmes, there were stark inequalities in uptake, such that the most deprived were the least likely to participate, with the greatest disparity that we noticed between the deprived and affluent for bowel screening. Next slide, please. So briefly, looking at this slide, for breast and bowel, women who had been prescribed antidepressants and had 3 or more comorbidities had much lower levels of uptake. The pattern was less clear for cervical screening. However, what is most stark about this slide, I'm sure you will agree, is that the women with intellectual disabilities who are represented in the yellow bars were less likely to have a record of screening for breast, cervical and bowel cancer than women of a similar age without intellectual disabilities. And the gap was bigger than what Pauline has just illustrated. For breast, the disparity was 25% lower among the women with intellectual disabilities in our Glasgow sample. It was 51% lower for cervical and 27% lower for bowel. And it's interesting because there's some evidence that for other conditions such as obesity or hypertension and diabetes, there is similar levels of uptake for people with and without learning disabilities. So it therefore appears that there may be a specific challenge relating to cancer screening in this group. Next slide, please. This is our paper, which was published in the British Journal of Cancer, if you're interested in seeing any further details. Next slide, please. So cancer screening should be accessible to all in society. We're giving everyone a screening invitation, but some might need more support than others. Professor Sir Michael Marmot, my former head of department, argues for proportionate universalism, which proposes that action should be of sufficient scale and intensity to be universal, but also proportionately targeted with greater intensity of action for those with greater social and economic disadvantage. So screening is universal, but evidence suggests that currently not enough is being done to proportionately target those who require more support. Okay, next slide, please. I'm now just going to briefly outline what our future work is going to entail. So now that we've noted these stark inequalities in access, failing to address these, as has already been illustrated, is a contravention of the Equality Act 2010, and at a more general level, in contravention of international obligations under the UN Convention on the Rights of Persons with Disabilities. Our aim is to improve access to cancer screening among people with intellectual disabilities, and we're planning to do this through a rigorous process of co-design. And as I said, my background is in cancer screening, and I don't have expertise in research with people with intellectual disabilities. However, through pure serendipity, our university offices, when we're permitted to be in them, are located on the same floor as the Scottish Learning Disabilities Observatory. And so through many informal meetings in the kitchen and in the corridor, we were able to work closely with our colleagues, particularly Dr. Deborah Kinnear, to develop a strong collaborative funding application to Cancer Research UK. And we were delighted that this was funded. I'm going to be co-leading this work with Dr. Marie Coetzer, and we'll start in the summer. And we're really delighted to have received this funding, as this topic has really been neglected within cancer research. So I'm just going to briefly outline what we have planned, but we really very much welcome your suggestions and your input into how we can make this research opportunity as useful as possible. Next slide, please. So we have four main objectives with our research plan. The first is going to be a systematic review, where we're going to systematically review the evidence in the published and grey literature. And if you're aware of evaluations that have been done, please do let us know, because we'd really like to include that evidence. So we'll do a mixed methods systematic review of randomized controlled trials and qualitative work, to produce, so that we can give in detail what components and mode of delivery and intensity of interventions have been shown in the international literature to increase screening among people with intellectual disabilities. Our second objective, next slide please, is to investigate the experience of key stakeholders in accessing cancer screening. And so we'll do this in two stages. Firstly, we're going to interview people with intellectual disabilities and their carers, and we will invite them through our networks within our steering group. But please do get in touch if you would like to support recruitment for this stage of the research in any way. We'll aim to achieve a range of participants who are eligible for cancer screening depending on their age and gender and the severity of their intellectual disability, and we'll strive to include ethnic diversity within the sample. And we'll include participants who have and have not had experience of cancer screening. The interviews will be facilitated by talking mats, and I've illustrated that in the slides, which is an innovative visual communication framework to enable effective communication for people of all abilities. And our team, including Dr. Deborah Kinnear, have expertise and extensive experience of using talking mats in this way. Next slide, please. Oh, sorry. We'll also interview family carers of people with severe and profound intellectual disabilities, so that we can also get the carers' point of view as well. Next slide now, please. In addition, we will conduct interviews with professional stakeholders, and I've listed them in this table. And again, if you feel that we've left anyone out, please do let us know, because we want to speak to as wide a range of people as possible to hear how people believe we can improve access, and we've already heard many great examples this morning. And by the end of Objective 2, having conducted the interviews with both the people with intellectual disabilities and the professional stakeholders, we hope to have a really good sense of what the key barriers are and potential solutions. Okay, Objective 3 on the next slide, please. So we'll gather together the evidence that we get from our systematic review and the stakeholder interviews and develop recommendations which will also be informed by relevant theoretical frameworks to develop suggested recommendations, which we will then take to a co-design workshop where we'll discuss the draft recommendations with our multidisciplinary steering group, including people with intellectual disabilities and professional stakeholders. And then in the final stage of this research project, Objective 4, informed by the first 3 stages, we want to test and refine the acceptability of interventions to address low uptake of bowel screening among people with intellectual disabilities. And our initial focus for intervention development will be in bowel screening because people with intellectual disabilities have a higher risk of bowel cancer. And we aim to take forward the most promising recommendations from Work Package 3. And we will test and refine on a small scale the potential interventions with stakeholders to clarify acceptability and optimum content. And the proposal would be that we would then take that on to a larger trial for feasibility testing. Next slide, please. Finally, I'd like to suggest that our cancer screening programmes offer an excellent opportunity to develop a learning health system, which was described in the New England Journal of Medicine recently. And learning health systems are characterised by continual improvement and innovation, with new knowledge capture as an integral byproduct of the delivery experience. So my ideal would be that as a result of this research, we'll have a number of potential interventions which we will test within the current cancer screening programmes. Some of these interventions may work, others may fail, but we have a system where we continually learn and develop evidence for what the most effective strategies are. Final slide. Thank you so much for listening and for this opportunity to share research with you. I'd be delighted to hear from you if you have any suggestions or comments on how we can make the most of this research. Thank you.
Thank you very much indeed, Katie. I'm really pleased to hear that you're going to be trying some of the proposals out in real life, so we can see whether they do actually raise uptake, because it's an incredibly important thing to do. So I'm going to move swiftly on to my own Dr. Kevin Dunbar and Steve Robinson from NHS Digital, who are now going to talk about reasonable adjustments, the issue of marking knowing who needs reasonable adjustments came up this morning, and whenever I talk to people about inequalities, the issue of data access and flagging comes up. So over to you, Kevin and Peter. Thank you. Steve, rather. Oops.
Thanks, Anne. Yeah, so I think this is a really important issue, and it's been raised a couple of times by our previous presenters. And the issue is one of how do we solve the challenge of ensuring that the right information goes to the right people to enable them to access screening. So I'm Kevin Dunbar. I'm one of the public health consultants who works for Anne, and I lead on the information governance and the Caldecott functions within the PHE screening division. And so I work with Mike to ensure that we can get the right data to make the right delivery choices within the screening programs. So next slide, please, Mike. So what's the problem? I think we've already established this, and it's been said more eloquently than I will, but there are many people who can benefit from screening, but they're not able to access it because of simple barriers. And this isn't simply restricted to learning disabilities, it's any range of barriers. For example, getting a leaflet in the wrong language. And as has been said before, we have a legal duty and an ethical moral duty to ensure that we can minimize these inequalities wherever possible by ensuring that people get the information that they need to make an informed choice about screening. So our aim internally is pretty obvious. We need to identify people who can benefit from the better information in order to provide that information so they can make a clear decision about screening and they can take it up where they want it. We need to make sure that the information is given to them in a way that they can use it. Next slide, please. The challenge is, and Pauline touched on this really clearly, is that the data is hard. It's hard to get. It's a combination of things. It's held in separate places, and it is held under special constraints because your information about your health, ethnicity, language, these are all things that are held with a duty of confidentiality by NHS services. So you need special permission to access them. And some things are difficult to access because of the way that the data is coded. So for example, learning disabilities are coded in a range of different ways because there's a wide range of diagnoses that can have this effect. And so in an ideal world, what you'd have is a solution that incorporated the patient's determinants of what they needed or their carer's determinants of what they needed, some sort of flag or information that explains what a patient wants and how they should get information. And we should have some sort of clear legal bounds to access this information and use it to go ahead and generate invitation leaflets and information that is best suited to our participants. So I'm very happy to tell you that we then came into contact with the Reasonable Adjustments Flag team in NHS Digital, and I'm going to hand over right now to Steve, the inimitable Steve Robinson, who is the project manager from NHS Digital's Integrating Care team, and they're developing this Reasonable Adjustment Flag in conjunction with the teams from NHS England, and we're very excited to learn more about this and to see how we can use this and incorporate this into our screening programs.
Okay, thank you for the introduction, Kevin. I'm going to be talking about sharing reasonable adjustments across health and care using the reasonable adjustment flag. What I'm going to do today is talk about why we need a flag, what's been developed, give you a quick demonstration and look at some of the benefits and feedback we've had from piloting the capability, talk about potential considerations for screening services. Obviously, this is the start of a conversation, and then look at where we are and next steps. So why do we need a reasonable adjustment flag? Well, as Pauline clearly stated, there's a legal requirement and a raft of legal requirements. The Equality Act itself says that organisations providing the services must take steps to remove barriers that individuals face because of disability. The reasonable adjustments. And we know significant steps have been made in terms of providing reasonable adjustments. Ramps have been built into buildings, doors have been widened. There's lots of other changes that happen. But the findings of the confidential inquiry into premature deaths of people with learning disabilities found that patients who were dying 20 to 30 years younger than other patients, it was partly due to the fact that they weren't receiving reasonable adjustments to care. The services were not being necessarily adjusted to meet their needs. Part of the problem is that patients weren't identified, and when they presented for care, organisations might not know they had a learning disability. But it's not just about learning disability, it's about what are their needs, their adjustments to care. So the learning from the SIPOL report was taken on board, and we've got a long-term plan requirement that by 23-24, digital flag in the patient record will ensure staff know a patient has learning disability or autism. But of course, it's not just about knowing their conditions, it's also about knowing their adjustments to care. So I'm now going to talk about the flag itself. So the reasonable adjustment flag indicates a patient requires adjustments to care due to impairment. The flag aspect is important and it's meant to be highly visible in systems, whether you call it a flag or alert. The key aspect is that although we already know that some reasonable adjustments are well recorded in local systems, in the summary care record, quite often people don't get to see that information until they read through the clinical record. And it's possible the patient's been sat in a noisy reception, suffering in the meantime. So that flag or alert aspect is quite important. But of course, it's also a record. So it includes details of patients' key impairments to provide context for the adjustments, so details of disabilities or long-term conditions, but this is optional and the patient may prefer not to say. It includes key adjustments to care that can help a care episode go well or happen at all. So for instance, it could include the provision of easy read information, a longer appointment so that the care can be provided fully and they can understand what care is needed, that a carer should be present and involved. And the adjustments are built around the existing accessible information standards. That's DCB 1605, which is a data standard which defines key communication requirements. That's one of the key reasonable adjustments you need up front to be able to communicate with patients effectively. It's an expectation that the flag we've created can be created or viewed by any relevant health and care professional across the whole of health and care, so that includes social care as well as NHS. And the flag itself has been built into the NHS spine and currently can be accessed through the summary care record application, which I'm going to show you in a minute. We've piloted that in Gloucestershire and Devon, and I'll talk about some of the feedback we've had from there. But in the future, it's important that the information that's in the flag is really shared and integrated with clinical and other systems such as screening. So we're developing a software interface to link up the systems, and that will pass around what's called FIRE messages containing key information about the flag, reasonable adjustments and details of impairment. So let's have a quick demonstration. So I'll just pop up the NHS spine. So if you're given a smart card and you're allowed to access information on the NHS spine, you'll be given access to the spine portal. You can click on the summary care record entry there to invoke the summary care record application, which I'll now show here. So as you can see, it's a web-based application allowing access to key clinical information on the spine, principally the summary care record. It's viewed 200,000 times a week for summary care records. Now that we've introduced the reasonable adjustment flag into this, that's 200,000 opportunities for people to see a reasonable adjustment flag. Like all systems, it's got to find a patient. In the long term, we'd expect the same capability to be built into clinical systems. So I'll search for a patient, find the patient. I'm working with D. I'll just check we're in the right record. That's the right address. Date of birth's correct. There's something interesting here. This flag up here is indicating that D requires reasonable adjustments. She's one of the 20% of patients with a disability. We may need to adjust our service. If I click on that tab and drop into the record, we can see there's a header, talks about the Equality Act and the need for reasonable adjustments. The expectation is that all staff across health and care will be aware of reasonable adjustments, the need for adjustments and what those look like. We then immediately drop into a section which contains 2 reasonable adjustments. I'll look at those in a second because I'm just going to scroll down a bit, look at the next section, which is patient's impairments. It says patient impairments to consider when making adjustments. In this case, we can see that D has a learning disability that's been coded, and a little bit of an extra detail. It's a moderate learning disability was added. Down the bottom of the record, some information about how consent was created, was obtained to create this flag, whether it was by the patient, with somebody with power of attorney or in best interest. Details about the organisations that created the flag, found that the patient requires reasonable adjustments, and that you could contact that organisation for further information. As you could see here, if we wish to delete an impairment because it wasn't correct, we could delete it. We can add more patient impairments as time evolves. We'll look at that again in a minute. So going back to the reasonable adjustments, we can see here we have 2 reasonable adjustments on this flag. The flag's not meant to be a full repository of all reasonable adjustments. It's what are those key ones to help the episode go well. The rest of the information is to be expected to be found in appropriately shared local records and other records such as care passports, that kind of thing. So we can see here the first adjustment requires contact by telephone. That's a coded item SNOMED from the Accessible Information Standard. It's a specific contact method. A little bit of extra detail provided in that D will not answer the phone the first time you ring, so when contacting to remind about appointments, please leave her a voice message with your contact details and she will phone you back. This is a real world example of an adjustment that was made to ensure that they got hold of the patient. They can now contact that patient. The second adjustment here is labelled and coded as a requires reasonable adjustment because this is our bespoke reasonable adjustment. We know that many adjustments, and 50% of those adjustments created in the pilots, were actually bespoke adjustments, and this one's about the fact that D becomes agitated when she meets people wearing green jumpers, to the extent that she won't be able to engage with you and you may not be able to carry out the intended care. So where possible, please make arrangements for staff not to be wearing green jumpers or cover them up. Another real world example. If things change, D becomes happier with people with green jumpers, it could be deleted. Maybe it needed to be changed, which is deleted and a new one would be added. What I'm going to do now is just show how easy it is to add another impairment and adjustment. So if I scroll down to learning disability impairment, add more patient impairments, I've dropped into the flag creation mode. These are the 4 steps you go through when you create the flag. People say it's very easy, it's a 2-minute job. Consent's already been recorded. We're now looking at impairments. In a minute we'll look at adjustments, and then we can review and save it on the spine. So this is how you define the impairments. A simple list. This list is currently in review because we're likely to change to a list of impairments in line with the new harmonised impairment standard. But let's say that D's got older, she started to develop dementia, that's become significant. I can just tick dementia there. I could add further context if necessary, but I'm not going to do that. So I just click review and save. We're now looking at what's going to go to the flag. We can see that dementia has been added above the learning disability. So if I confirm and save, that's now updated the flag on the spine. But I also want to add a new reasonable adjustment. We've got 2, let's add a third. Let's say, give an example that D uses a very large electric wheelchair now, and that's significant. So you can see I clicked add further adjustments. I'm back in the reasonable adjustment mode. So on the right hand side of the screen, this is showing me the existing adjustments that D has on her flag already. If I scroll down a bit and look on the left, these are all the new categories of new adjustments. So at the top, we've got accessible information codes, communication requirements, does lip read, things like that. You can drill into those, select them by clicking text boxes, newer categories of adjustment down below. So individual care requirements, anticipatory care plan, needle phobia, extended appointments, they're all there. So you can choose to drill through these, learn from the categories. At the bottom, you can see we've got our bespoke or reasonable adjustment, but I'm going to show you a very quick way of finding an adjustment. So let's say we know it's about wheelchair. I can type WHE in, and if I just pull my screen down a bit, it's identified all the codes using WHE. So there's one about home visits where possible, but there we are, requires wheelchair access. So I just select that, click add, and see it's been added to the right hand side. And I can just add a bit of text there, just large wheelchair. Obviously, you can put further detail in there to clearly state what the significance of that is, but usually that means it's difficult to get more difficult to get taxis, more difficult to perhaps manoeuvre where it's a very large wheelchair in certain environments. So I click save. So once again, we go back to review and save. I check what I'm looking to add onto the spine. Requires wheelchair access. That's an adjustment to the environment to make sure there's enough room for it. I confirm and save, and I've now updated the flag. So if we just scroll down, we can check reasonable adjustments, requires wheelchair access is in there. That's mentioned along with the 2 other adjustments, and the key impairments are there as well. So that's how easy you update the flag. Creation is only a slightly longer process. So let's now go back to the presentation and look at some of the learning for feedback from the pilots that we've done. So the purpose of the pilots was to establish, have we built the thing right, but also have we built the right thing, you know, for the business purposes it's designed for in terms of reasonable adjustments. So we did that in Gloucestershire and Devon. The users really like the easy structured approach to defining reasonable adjustments. They hadn't done it that way before. They want to see it in their clinical system because it's very quick and easy to do. The initiative itself prompted collaboration between organisations. What do good adjustments look like? So that was really good to see. But there's also an awareness that we were dealing with learning disability specialists who understand reasonable adjustments really well. The broader cohort of staff across the whole of health and care perhaps don't have that awareness, and therefore there's a need for extra training and awareness. New examples of code started to emerge. So in emergency call list team, the fact that patients use an emotional support pet, there's other key adjustments that haven't been coded, don't exist in terminology, but they're really great examples to share and would be coded in long term. Carers themselves don't get reasonable adjustments in terms of they're not eligible, but they feel the benefit that the patient they care for is getting reasonable adjustments, and they're really supportive of the initiative, and they feel reassured if they know that health and care organisations know they need reasonable adjustments. So one example was a mother with 2 sons with autism, and she says if she knows the organisation is prepared to work with her and help her, she's likely to go there at the end of a busy day, stressful day, to that important health appointment if she knows that she won't be just treated as a parent with 2 unruly kids. So other benefits, so I'll quickly fly through these. It's to be created, updated and viewed in any health and care setting. So it's a national solution to sharing this information. The fact that we have a explicit consent model, in other words, you engage with patients and carers to understand their needs, prompts a discussion with patients and carers. That's really valuable. The flag aspect of it, it means that it's visible to organisations providing care as soon as a patient is registered or referred. So it means that organisations can prepare in advance. It's not a matter of reading through all the clinical records and establishing a patient's needs that way. The structured approach helps organisations to share and make better adjustments. And we're really seeing this as a catalyst for a reboot of reasonable adjustments and the way it's delivered across health and care. And NHS England are working on hard to do the groundwork for that. And in the broader way, better adjustments, so better communication results in less delay to treatment, more personalised, patient-centred, safer patient care, which leads to improved care in general and better health outcomes. So what kind of considerations are there for screening services? Well, although we've worked in the learning disability space, a patient with learning disability can have any other physical disability or impairment, and the capability has been designed to be relevant for all patients with disability under the Equality Act. So that's up to 20% of patients who may ultimately get a flag or require one. The key considerations are, well, if you're inviting patients for screening, the accessible information standard is built at the core of the flag. Therefore, that will provide key communication information to help you interact better with the patient. But of course, we've now developed further categories of adjustments around additional support. Will additional staff be needed when you're carrying out the care episode? Does the person have individual caring requirements in that they might need to be need a longer appointment, the first appointment of the day, the last appointment? Will the environment need to be adjusted in terms of low light, quiet environment, and of course also the bespoke personalised nature of adjustments as well? The flag's been built to be used in direct care by all members of the extended care team, so we expect receptionists to see that the flag exists so that they can work with their colleagues to ensure adjustments are made, but also for services such as screening. But obviously there are information governance requirements about how that is used, and that will have to be dealt with accordingly going forward. A final point, I think it'll take a significant amount of time before all relevant patients have a flag and all relevant systems are integrated, and that sounds a bit of a downer, but I don't think it is really, because one of the key things we say about this work is it's not about the flag. It's about the basic groundwork in identifying patients, engaging with them, understanding their needs and recording it in your local systems in a structured way. Then you have something to share with colleagues. So finally, where are we now? So over the next 6 months, NHS Digital are making technical updates to the system. So that's around the existing capability in SCRA. New codes are being released. We're also working on an information standards notice so that suppliers will need to do it, and that software interface for integration, which should be available in the second half of the year for wider use. And the key thing is that NHS England are doing the bigger, wider awareness piece. So they're doing guidance for local organisations, local business change, and there's 7 early adopter areas already working on this business change groundwork. So that's moving on. The final point is that there are other potential developments that can be considered, such as learning from deaths reporting. Referral systems could use the capability to indicate a patient needs adjustments. So that's where we are. And for further information, there's a link there. You can go look at our website, and there's also contact details there. These slides will be shared after this meeting. Thank you.
There we go. Unmuted. Yeah, thank you so much, Steve. So I was just looking through the questions actually in the Q&A chat, and I think some of this will answer some of those. I mean, obviously we're really excited about this. We think this is absolutely essential work, and the NHS has been working on it for a while. In order for us to integrate this into the screening programs at large, there's still a handful of steps that need to be taken forward. So we do need to establish user acceptability, but I think actually NHS Digital have gone a long way towards that. And we've already started asking focus groups about how they would find the use of their data acceptable, and we'll continue to establish that. But I don't foresee there'll be any problems, because this will be largely a user-driven flag. And it will be the patients and their carers who are able to establish and consent for what goes into the system. The second and harder thing is work on how we integrate this into the screening systems. And there's a lot of questions in the side about, will this be integrated into BCSS and NBSS and the other systems? The truth is we need to work with NHS Digital to access the data. We need to work internally in our programs to ensure it's integrated into our call recall systems nationally, and that takes time. And we need to make sure it's integrated into the new call recall systems. And as many might be aware, there is work going on to upgrade and update the call recall systems that exist, and we need to take that system through the process of integrating into this data. So we should, in theory, in the future, be able to directly access the flag, and that should allow services to accurately identify patients who have needs, and for the call recall systems to send out letters that are appropriate. Finally, and this is a small boring thing, but I just want to mention it because there's a comment in the side, we do need to get Section 251 support for screening QA, not for the use of this to call, but to get our access in order to ensure that services are being delivered to a satisfactory standard. There's a comment in the side about how information governance is cited as a reason for not sharing, and I just want to say I'd echo the point, which is we should all lean a bit on Caldecott 7, which is that the duty to share information can be as important as the duty to keep it confidential. This information is obviously really important. It is for patients to improve their access to services that they want, and they will have provided it voluntarily. So there really shouldn't be any information governance barriers to any of this outside of our need within Screening QA to get access to it for non-direct care purposes. So anyways, thank you very much, Steve. That's my last slide. Thanks, Mike. You're on mute, Anne.
Thank you. First time all day. Thank you very much indeed. I know that people listening will be really pleased to see the progress on this, because it comes up every single time we start to talk about making things better for people with protected characteristics of all sorts. So I'm going to get Johnny to come back and ask us some questions through Menti about the reasonable adjustments. So Johnny, over to you.
Thanks, Anne. So to recap quickly on Menti, for anyone who missed it this morning, I'll ask some questions via Menti and show on screen everyone's anonymous responses. All you need to do to get to the questions is either use this QR code via your phone camera app, or go to www.menti.com and type in this code. And you can see the instructions again at the top here, if you need that. So the first question is, how would you rate the reasonable adjustment flag system demonstrated by NHS Digital?
Oh. It's exciting, isn't it? You're going to make 9. No, I think that's. I mean, I think this is, from what I've seen, is a real, really exciting improvement, both for clinicians, of course, but as secondary users of data to assess the effectiveness and accessibility of the screening programs. I think it's going to be incredibly important. Thank you. Have we got another question, Johnny, or is that it?
Yeah.
Oh.
So next, what do you like and dislike about this approach to the reasonable adjustment flag? This is one where you need to type your answer in.
I assume secondary users will be able to access something. Is that right? So we will know something about how many people have got need reasonable adjustments.
So, and that's where our Section 251 approval will come in. Is when we need to use that data for a screening program called Assurance. So we should have access to that.
So in theory, yes.
And we've already got approval for certainly for preferred language and Braille and easy read leaflets in the AAA program. So we'll be able to get access to that data. We'll be allowed to have access to that data when it is available for the other cancer programs as well.
Brilliant. This will make a huge difference, I think. Wonderful.
And finally, for this section, if you are a screening provider, how often would you use the reasonable adjustment flag system?
Right. I think that's a vote of confidence there, Steve. Yeah, hope it works.
Yes, I think you're right. Yeah, it's very helpful to know that. Thank you.
Yes. These will all be available once the system closes down. Once the conference is done, so you can take it back to NHS Digital and share the views. How many have we got on, Johnny? How many people are voting? Oh, can I? If I count all those numbers, that's the answer, is it?
It's down here in the bottom right, so we've got 140.
Okay. All right. Wonderful. Well, is that it, Johnny? Have we got any more questions?
Back over to you, Anne. Thanks.
Okay, wonderful. Okay, well, in which case, I just want to say thank you very much indeed to Stephen, Kevin, and to the speakers that we've had so far. I'm going to let us all have a cup of coffee and a comfort break, and I will see you back at 2:15, if that's okay. Thank you very much. See you later. Welcome back, everybody. I hope you had a nice cup of coffee and at least you stood up very briefly. I would like now to introduce Lucy Fagan and Sam Field from the London Borough of Southwark, who are going to talk to us about the development of a toolkit for local authorities to support screening recovery during the coronavirus pandemic. And they said they will do a focus at least on learning disabilities as part of that. Thank you very much and welcome.
Brilliant. Thank you, Anne. Brilliant. So as Anne mentioned, sort of building on really an exciting afternoon of discussions around screening, we wanted to come and talk a little bit about the impact of COVID-19 on screening inequalities, but also what that means in terms of the role of local government in being able to discharge its responsibilities around health inequalities and support screening recovery. Next slide. So, and this won't be news to anyone, but really just thinking about where we are now a year into the COVID pandemic and what this has meant for screening programs. We know that COVID-19 has significantly impacted the cancer landscape here in the UK, and that's from screening services all the way through that pathway through to diagnosis and treatment. Particularly with screening services, we have seen a huge impact. There was the backlog that was created after a pause in screening programs earlier in 2020, and we now find ourselves with considerable pressure to try and address this backlog in screening appointments. At the same time, responding to some of the challenges about really maintaining safe and appropriate care during the pandemic, we know that service models have also changed. So, for example, the recovery programme for breast cancer screening has reduced significant changes to the screening programme, and that includes, for example, not using timed appointments or smart clinics. And really what this means is, as we seek to try and restore screening programmes and address this backlog, it's really important that we continue to retain a focus on how we reduce inequalities in screening uptake. It's not enough to go back to where we were, but actually it's an opportunity to build a more equitable approach to screening. Next slide. And so many of you will be familiar with this from the PhD screening inequalities strategy, but we know that screening inequalities can appear at any point in the screening pathway, from invitation through to access to services and treatment and to outcomes. And we know that these inequalities play out at many levels. So everything from the national level to regional level, for example, in London, through to more local level. And it's important that we take into consideration the opportunity for change and reducing inequalities at all stages of this pathway. Next slide. So we know that the pandemic risks both exacerbating existing inequalities in screening coverage and uptake, but also creating new inequalities. And I think it's worth at this point also emphasising that these inequalities do intersect. You know, we are not having one person presenting with one potential inequality, but actually there are groups that are particularly marginalised and more exposed to these inequalities. So some of the key groups that really are experiencing inequalities during the COVID pandemic when it comes to screening include those who are clinically vulnerable. So those who may have underlying severe health conditions, particularly those who during this period have been identified at times as needing to shield and therefore may experience new barriers to accessing screening. They may also just be generally more anxious about attending, and there's a need to try and provide assurance around continuing to access screening amongst this population. We also know there are higher risk populations who will be impacted by screening inequalities. Those, for example, who are at high risk of COVID, so think about BME populations, who are already at higher risk of screening inequalities, are also at higher risk of severe complications from COVID-19. And this means that it's very, very important that we actually seek to understand better around some of the screening inequalities that exist amongst this population. There are carers, and carers also are particularly impacted during this period. So we know that carers who provide care and support for people, particularly perhaps those with learning disabilities, are experiencing further barriers to accessing screening. They may be more anxious or reluctant to attend because they're concerned about some of the vulnerability of the person they care for, but they may also suffer from some more practical barriers. So, for example, not being able to access, care or support to actually allow them to go and attend that appointment. And then really coming to, the crux about what we've been here talking about today, also for people with learning disabilities, they are also at risk of greater inequality during this period. They may need increased support to regain their confidence in engaging with screening services, and I think this is particularly likely if the service model has changed. There's also some very practical issues, for example, access to transport, access to support, to really engage with screening services, and these are things that are more challenged and under more pressure at the moment due to pressure on services. And I think we've just touched on here, I think, you know, there are wider challenges that also, just on the next slide, there are also wider challenges that affect everybody, and those who already suffer from screening inequalities may be more at risk. So we know that even after the pandemic, factors such as fear or mistrust of healthcare settings, you know, potentially poor experiences during this time, a lack of information about whether services are actually available again. These are all factors that may influence screening uptake beyond the scope of this pandemic. And we also know that there will be a lot of changes and stresses in people's lives. So, you know, financial, family, health, which all affect whether someone will actually be able to take up screening at this point. It may be deprioritized, it may not be the most immediate concern. And so thinking about all these different kinds of inequalities and who is potentially most disadvantaged by the impact of the pandemic must be a critical part of all screening recovery. And these all feel like these feel like bad things, these feel like challenges, but I think also this increased focus on health and inequalities that the pandemic has exposed also give us a greater argument to talk about building back better, which we've all heard, but actually really thinking about if we're looking at screening recovery, it's not just about going back to where we were with all those inequalities that we already faced, but thinking about how can we make screening, you know, access to screening, but also engagement with screening better for those who have traditionally experienced inequalities. And I think for people with learning disabilities, this is a really important opportunity to think, how can we do it better? And then, you know, this feels like a big ask, but who should be doing it? And I think this is really where we wanted to talk a little bit about the role that local authorities and particularly local public health teams can play in supporting screening and recovery and really keeping the focus on health inequalities. Next slide. So some of you will know this, and for others, perhaps it's a useful reminder, but local authorities can play an important role in addressing screening inequalities, even when they're not directly involved in delivering the service. So the wider determinants of health have a huge impact on screening uptake, and many of these wider determinants fall within the remit of local authorities. So we're thinking about things like, you know, health information, we're thinking about access to transport, we're thinking about connection with the voluntary sector. So improving sort of uptake of screening services can be a really important part of a local authority's role in implementing a public health approach. We also know that local authorities, I've given public health teams here as an example, but actually local authorities generally are also really important community connectors and facilitators. They know about their community, they know particularly where areas of deprivation are, they know where those community assets are, so key voluntary sector organisations who are, you know, supporting vulnerable groups, and they understand how to build those relationships and really deliver more person-centred services. And so this puts local authorities in a really good place to help support this screening recovery and to help address some of those local inequalities. So I just want to talk a little bit about what this might look like. Next slide. So, and I don't think I've got time to go into detail on all of these, but I think, you know, really to highlight some of the key areas where local authorities can support screening recovery and help address inequalities. So scrutiny and assurance is a key one. Local authorities play a really critical role in making sure that services are delivering on their health, addressing health inequalities, and have a very embedded scrutiny structure to where reports around screening and screening quality can be brought in. Joined up commissioning, because local authorities commission a lot of public health services. How can we integrate screening into this and make sure that these are complementary rather than two different systems? This role about supporting and empowering local communities is a really important one, and actually engaging with communities to understand why they might not be accessing screening and how we address some of those barriers. And this also links with strategic communications. I wanted to really touch on leadership on health inequalities. You may be aware that local authorities have a legal duty in relation to health inequalities, and this can be a really important tool for change. One of the areas of work, and we'll touch on this a little bit later, is, local authorities can also really support in helping engage around joint strategic needs assessments, health equality audits, and really start to work with screening teams to understand what are the inequalities faced in local communities and how can those be addressed. And equally working in partnership, so linking with the voluntary sector, linking with the local CCG, and really making this everyone's business locally. Next slide. So we're just going to talk through a couple of examples of work that Southwark has been doing to really just illustrate how local authorities can play their part in screening recovery. So just to touch on this one, this is a rapid impact assessment with a focus on cancer screening that was undertaken back in June 2020, as you can see by the date, to really start to unpick what was happening with cancer screening locally, with a focus on what were the inequalities that were being created and what were some of the risks to the local population. And this was done in partnership with local screening teams, with local stakeholders, and really started to bottom out who were the most vulnerable groups who are at risk of not being able to access screening and what could be the wider population health impacts. And I think this was for us a really important piece of work in terms of really setting a direction around particularly people with learning disabilities and other more vulnerable groups who we knew would be at greater risk during this time, and sparking that conversation with stakeholders about how we implemented health improvements. And then I wanted to touch on the next slide, and I'm going to hand over to my colleague Sam, but the local authority is also playing a really important partnership role with the South East London Cancer Alliance, and I just want Sam to maybe talk a little bit around this evidence review that she did and how that's engaging with the screening recovery programme.
Yes, thanks, Lucy. So I performed a review of evidence on how to reduce breast cancer screening uptake inequalities, and this was to assess whether there's any specific interventions that had a good evidence base that we could invest in during the recovery phase. And I suspect my experience will illustrate the difficulty local organisations have in translating evidence to practice. And I'm sure you're all very familiar with that, but as many speakers have already alluded to, the evidence in this area is very inconsistent and in some places lacking. So my findings were that although there's good evidence in outlining which groups have low breast cancer screening uptake, overall the interventions that we know have a strong evidence base are already widely in use. So it's difficult to identify novel interventions that can be used. And another challenge is that there's a lack of evidence specifically geared into reducing breast screening inequalities rather than increasing overall uptake. So it can be challenging, but there was good evidence that the use of community-based healthcare workers can help increase breast screening uptake in disadvantaged groups. But when we think about putting it into practice, it's slightly more complicated, as actually in the evidence there's a lack of consensus on how they're best deployed. And other interventions like follow-up telephone calls, behavioural insight interventions, all these show highly mixed results between different subgroups and in different settings, which makes interpretation of the evidence even more confusing. I suspect that it's because different subgroups experience different barriers to uptake, and there's also a significant amount of geographical variation. So there's no one-size-fits-all approach. This makes it really difficult for local screening organisations to understand what to focus on when what works in one setting or for one group might not work in another. And of course, there's the added complication that barriers to screening are changing post-COVID. There was a lack of good evidence looking at digital or virtual interventions, and I suppose this is one area that we could really look into after COVID. So even though this review focused on breast screening only and it wasn't exhaustive, it would be interesting to know how people in other organisations and on other screening programmes are able to translate evidence into practice. So back to Lucy.
Great. Okay, next slide. So we wanted to finish off by talking a little bit about how we as a local authority, along with other local authorities across London, are really starting to engage in this conversation around screening recovery and inequalities. And this is particularly focused around a piece of work that's currently in development, which is a local authority toolkit on breast cancer screening recovery. And the idea is to provide a step-by-step guide to local authorities to help them understand how they can discharge their responsibilities, but also leverage their capacity to be able to support breast screening recovery and also to reduce inequalities along the way. And it includes recommendations on how to assess the impact of the pandemic on local screening inequalities, key ways to improve communications, particularly for the most vulnerable groups, how to support outreach, and how to better integrate screening into wider COVID-19 response and recovery activities, which is a key area where local government is really focused at the moment. And the idea is that the toolkit should also feature good and emerging practice from local authorities to help reduce these screening inequalities and explore areas for learning so that we can learn from each other and see what can be done, depending on your local population, tailored to your local context. And really what we wanted to end with this was actually, this is an important piece of work, but it's really important that we, make sure that it actually addresses some of the inequalities faced by people with learning disabilities. And in it, we really want to look at strategies for improving access to screening for people with learning disabilities, and also capture examples of local good practice and partnership for screening recovery. So I hope that this was some interesting food for thought, and what we would really like to hear from you during, your comments, but also you can contact us afterwards, is some of these examples, is some of these ideas, and really thinking about how local authorities can play their part in improving the work that screening teams are doing, and really make sure that we provide a more equitable service as we move to recovery and restoring our service provision.
Thank you very much indeed, Lucy and Sam. It's really good, and it's really good and important to hear from local authority colleagues. Quite often we talk to ourselves and to the providers, but not desperately often to local authorities. So I'm really pleased we've got you in our net, by which I mean our network. So I'm delighted. I would like then to introduce our final speaker, who is my own Nick Johnston-Waddell, and he's going to follow on quite nicely from that, which is to present what national guidance and resources that PHE has developed and is planning to develop. Thanks, Nick.
Thank you very much, Anne. I hope you can all hear me okay, and I don't know quite how I'm going to follow the fantastic presentations from today, but I will do my best to give you all really what's going to be very much a whistle-stop tour of some of the ways in which Public Health England is supporting local screening services and some of the resources that we've developed. Some of these resources hopefully you'll know, and some of them you may not, and may be new to you. What I wanted to start by saying is that we always try to base all the resources that we develop on user needs. So that means we develop the materials that people like you tell us that you need to use, rather than making assumptions about what people want from us. And one of the main ways we've done that is by regularly meeting with people and talking to people with learning disabilities, and those of you who support them over the last few years, and we hope to do that again as soon, obviously, as social distancing allows. The other thing to say is that these days we design all our resources to be accessible, and that means that they can be used on different types and sizes of screens, and that they should work with assistive technology that some people might use, such as screen readers. So here's a summary of the resources that I'm going to be mentioning very quickly today. We've published animations, our easy guides, there are easy read leaflets. There was a question earlier about invitation letters, and we have already published some easy read invitation letters and are continuing to work on others in the future. We also have program specific guidance that we've produced, training materials, some that we already have and others which are in development at the moment. And then there's some more generic resources such as health equity audit guide, other guidance which might not specifically relate to people with learning disabilities, but which may still be useful. And I'm going to briefly end by touching on our text messaging work as well. So the first thing that I was going to mention is some of the animation work that we've done. Now, these animations that we've developed and published aren't specifically for people with learning disabilities, but we know that they can be particularly useful, and some of the speakers today have already talked about the importance of demystifying what happens at screening appointments and how the tests actually work for people. And what we try to do in our animations is to actually show what happens during each screening test, which we hope then will help people with learning disabilities to see what's likely to happen in advance and hopefully reduce anxiety. So we've asked some experts by experience to have a look at some of the animations. We've already published our antenatal and newborn animations, and we will very shortly also be publishing animations to show the screening tests which are offered across the rest of people's lives, both for men and for women. The feedback actually was very positive, and they said it was a good way of getting information across, and we'll be taking on board their feedback in the next versions of the animations. So one of the bits of feedback, for instance, was to slow the narration down a bit and to make sure that any text on screen isn't too small. What we'll also do is to add subtitles, which we know from feedback can be really helpful for people with learning disabilities. Talking to my own children, however, I've got sons who are 11 and 13. They're obviously the experts at all things digital in our family, and they tell me that for videos on YouTube, it's actually already possible to slow the soundtrack and to slow the video down slightly. So there are already ways in which we can tell people how to do that. Now, what I was going to do is actually show you one of these animations, but I think we're running slightly late, so I'm not going to do that. But we will be making the animations available. I think you can just see one scene from there, from one of the animations there. So I'm not going to show that to you all now, but we will be publishing these animations very shortly, and we always put out a blog about them, so keep an eye on the blog, and I will be telling you how to access the screening blog and how to subscribe to the blog in a minute. So in terms of our other resources, one of the most useful, one of the things that we've spent the most effort on over the last few years is to produce these easy guides, the easy read versions of our screening information leaflets. We published the first of these a number of years ago. And in 2018, we worked with NHS colleagues to review the antenatal and newborn guides, and we then worked with the Elfrida Society to make improvements based on the comments across all those easy guides. So we know that many people really like them when they're aware of them, but there is an issue, I think, around making sure that health professionals, especially people involved in delivering screening services, do know about these resources and can signpost people to them when they're needed. So absolutely loved Baroness Hollin's presentation this morning, for those of you who are around. And what we know, of course, is that for some people with learning disabilities, different approaches can be really useful. So some people actually find those easy guides where there are words and pictures helpful. Other people just prefer a pictorial approach. So I'm really pleased that we're going to be working with Books Beyond Words. That's what we're hoping to do over the next few months, to bring their cancer screening leaflets up to date, so that we can provide that range of resources to people. So, like I said, there were a few questions earlier about easy read invitation letter templates. This is an example of a template for abdominal aortic aneurysm screening. So some of these we've already published, and others we will be working on over the next few months. In terms of program specific guidance, I think what we're trying to do is pull together guidance to support health professionals working in a particular screening program on the types of reasonable adjustments that they should be considering. A lot of these things have been touched on much better than I could by presenters earlier on today. So here's just a few examples from our guidance about supporting women with learning disabilities to access breast screening. And many of these things have already been touched on. So things like extra time, simple language, finding out what word women use for their breasts, using an appropriate venue, the possibility of offering a pre-visit, things like music, showing the machine, and obviously going at the right pace. So hopefully some of the program specific guidance is useful. It sounds to me as if there are so many good ideas from today's session that we might be able to update that and include some further ideas in that guidance in the future. One quite exciting thing that we're working on at the moment, and unfortunately has been slightly delayed due to COVID, but we hope to pick it up again soon, is a new training resource, a new e-learning module, which will be around making screening accessible or making it more accessible. And this is a resource which is intended for local screening services and the people who work in them, with the aim really to base this resource around the experience of individuals using screening services, or people maybe who've not had a good experience of screening services for whatever reason. So we're going to be basing this resource around filmed clips, vignettes of individuals, including, really importantly, people with learning disabilities, to share their experiences and their suggestions for how local services could be made more accessible. We already have some guidance, of course, hopefully some of you will be aware of it, which is more generally applicable to inequalities, not specifically on learning disabilities, but obviously useful in this area. So we have our Health Equity Audit Guide, which provides a series of questions to help develop ways of addressing three areas. So identifying health inequalities in the people eligible for screening, then assessing health inequalities in relation to screening, and then finally identifying the actions that you can take forward to help reduce inequalities. What we've also done already is to publish guidance in a couple of different areas. One of those is for people who are trans, and another is for people with severe mental health conditions that we know sometimes might need some extra help accessing services. We're also currently working on guidance to support screening in prisons, and also, I think really importantly, because this has been mentioned quite a lot today already, people who are carers, so someone who might care for someone with a learning disability. And how they can help and support the invitation process. And we hope to publish both those bits of guidance by the end of March. And in the longer term, we're also hoping to develop guidance around cervical screening for women who find it hard to attend due to previous traumatic experiences of some sort. So just very quickly, I wanted to mention that we've done quite a lot of work over the last year or so to support screening services to make more use of text messaging to remind people about screening appointments. We know that's a really cost-effective way of reducing barriers to screening attendance. And that's one actually which could help people with learning disabilities as well, because we know from Ofcom research in 2019 that although people with learning disabilities are less likely to have a landline phone, computer or smartphone, they're actually just as likely as other people to have a simple mobile phone. So the work to remind people about appointments through text messaging could be helpful, and actually we're also encouraging carers to be involved so that someone with parental or caring responsibilities could also get those reminders. And there's just an example. As well as the principles that we've published around text messaging, we've also developed a suite of standard template messages which hopefully screening services will find useful. So just finally then, to find out more, I've mentioned the blog a couple of times. The PHE screening blog is the best way to keep in touch with all our news. And there's a link on screen, phescreening.blog.gov.uk. What we will actually be doing within the next few weeks is to publish a blog about this conference, about today's events, and we'll be publishing as many as possible of the links and the resources within that blog. Then there's also a really useful page on gov.uk called NHS Population Screening Access for All, and you can find that easily just by Googling that, and it will take you straight to that page. So that was a whistle-stop tour of some of our resources. As I said, lots more coming up over the next few months. Massive thank you to all those of you. I know there are lots of you in the audience today who've helped us to produce these resources, given us feedback to make them better, and that really importantly includes experts by experience, learning disability nurses and support organisations, screening professionals and PHE colleagues. So thank you very, very much to all of you. And that's it from me. Thank you.
Thank you very much indeed, Nick. It was indeed a whistle-stop tour because there's absolutely tons of stuff to be found, isn't there? So, and I think a question I'm going to be asked in a little bit will allow me to signpost a few more. So we're going to have one last round with Menti. So Johnny is going to take us through a couple of Menti questions, and then we can go to some Q&As. Thanks, Johnny.
Thanks, Anne. So again, anyone who needs to get back onto the Menti page can follow the instructions at the top here. So the next question, if you are a screening provider, which national PHE screening resources do you use? Okay, I think it takes it's a bit more to take in on that one, so it's taking people a bit longer to respond. But
yes, there's lots of votes coming through, aren't there? This is really helpful feedback, Nick, isn't it? Shows you where to shows us where to focus. So the easy guide information leaflets are extremely popular, aren't they? Great. I guess one of the lovely things about these conferences with such large attendances is that if there is more stuff that you'd like us to do or things that you find helpful, then pop them in the chat or make a link via the screening help desk, and we can put them into the work plan or get back to you and discuss a little bit more about what you think might be helpful. Great show on a Friday afternoon. Fantastic.
Next, how do you learn about development in NHS screening programs?
It's been one of your huge achievements, the blog, hasn't it, Nick? One of the things that continues to be extremely well read and well loved. So it's very encouraging to see that that people get the information from there who've attended this. It's mesmerising, this, isn't it? I can sit and watch it all afternoon. Jiggle about.
And what should we all do next to help reduce screening inequalities for people with learning disabilities? Thinking about PHE providers, commissioners, or anyone else, and you can send more than one response to this one.
Interesting comment about the digital leaflets, actually. We need to continue to make sure that we provide information in a way that people can access and are helpful, don't we? In the shift to digital.
Thanks everyone. So, final question today is, what actions will you take away from today's conference?
So much, we've had so much content today, haven't we? I know that even I'm struggling to take it all in, and so I think seeing the information posted on the site and seeing who's posted it and making contacts, I think will be, I imagine there'll be quite a lot of that happening as a result of today. And Mike, you'll be pleased. Come on, let's have more of these sessions looking at other barriers. Mike has organised the day, and it's been absolutely fantastic. But I imagine you might want a little lie down before he does the next one.
At this
Yeah.
Can't hear you, Mike.
I was just saying, at least if I could have the weekend off first, that would be good.
Fair enough. It's a not unreasonable request. Sun shining, at least it is on me. I hope it shines on you and you get to walk out. Yes, I mean there's an awful lot of absorbing, I think, what we've shared, haven't we? I mean, I think part of the joy of this online mode has meant that we've been able to share a lot more than we would normally have done at a conference of a similar sort of length. So it's a very efficient way to do this, if on occasion slightly overwhelming. But so there's lots and lots and lots to share. And it's good to hear from academics and local authorities too. Fabulous. So it says the voting's closed. Do we?
Yeah, that's the last question. So back over to you, Anne.
Wonderful. Okay. Well, thank you very much. We're going to. I'm going to hand to Joe Harkin, who has been in the background collating the Q's and A's, and there will be opportunity to answer several of those. Just want to make sure that you know that if you haven't, if your question hasn't been picked this afternoon, they're picked on the basis of how many people have asked them or liked them. Then we will make sure that we answer them either through physically writing them and then making sure they're recorded, or responding to you if you've given us your full name, or you can ask the screening help desk. So Joe, would you like to pick up and do some questions? And we need to see all the presenters if possible. See your faces.
Okay, can you hear me okay, Anne?
I can hear you, thanks Joe, yes, welcome.
We've managed to extract a question for each of you, since a lot of questions coming in this time, but as Anne said, we have responded to some questions actually in the chat, and for others you can forward them to the help desk if we have your details, we can respond personally. So I'm going to start with a question for each of you, hopefully we'll have enough time. I'm going to start with Nick actually, a question for you Nick. The resources that you talked about, are the resources and animations available in other languages?
Yes, as far as possible, we do try to provide translations. So for our animation content, we provide English subtitles, and then we provide subtitles translated into the languages that, when we did an audit recently, people told us were most useful.
Thanks very much, Nick. That's really helpful. Now, a question for Lucy. Lucy, there are many requests in the chat for your toolkit, and could it be shared, please? Because people would find it useful to understand, especially when engaging with their own local authorities. So is that something you're happy to share?
Yes, absolutely, something we'll be happy to share. We're just finalising it at the moment, but we'll look at how to share it with the people who attended today, so that you can also understand, I guess, a little bit about what the local authority's role is and what they'll be prioritising, and hopefully find those areas of collaboration.
That'd be really helpful, Lucy, and if we can help you with that by publicising it via our blog, we're happy to do that. Okay, a question next for Steve Robinson. Steve, many questions came in about the practicalities of the flags. Now, some of them were answered in the chat by Suzanne and Philippa from PHE screening, but the ones that were the most popular, I will just ask again in case people feel that they haven't received an answer. So first, is it the GP's responsibility to add the reasonable adjustment flag?
No, it's not the responsibility of any one professional or role, but we have worked with learning disability specialist GPs who were very happy to do that. They could see the benefits of it. Other GPs maintain registers of patients with learning disability for the purpose of reasonable adjustments, and it could be assumed that for those patients they could set the flag, but in many cases it may be set by specialist community units or learning disability specialist nurses. But of course the problem for learning disability patients is the missing million. Not all patients are identified, and therefore it'll be by all specialities working together that people will get flags set.
Thank you, Steve. And the second question to you is, are call and recall platforms for the screening programs able to interact, extract from and act upon the flags from the spine?
Well, there's quite a few inherent sub-questions to that around technical capabilities and things, but the development has been created with the FHIR API. So if those systems can use FHIR APIs, they should be able to connect up and use the information. At the moment, the capability is designed for individual requests to the spine. In other words, you're working with a single patient, you want to know if that patient has reasonable adjustments, and it'll probably be that screening systems will want to know that answer for tens, if not hundreds of thousands of patients at a time. It may be that there need to be new batch interfaces written, but certainly these are the things that are to be thought of sort of going forward, and in terms of integrating systems. But I don't know of any reason why those systems should not be allowed to connect and get that information.
Thank you very much, Steve. I'm moving on to Katie Robb now. So Katie, we have a question for you around the cancer screening programme. So the question is, we've heard a lot of work about cancer screening programmes. Do you think this reflects better availability of data in this area, or is it about the support from charities and other sources of funding for research, etc.?
I think it could be two things. I think, as Pauline illustrated, there's more evidence for cervical and breast screening, and they're longer established. They were introduced in 1988, whereas bowel, AAA and diabetic eye screening are more recently introduced. But I would say possibly there has been more funding linked to the cancer charities, but I don't know, because they are more recent, the other related to diabetes and AAA, maybe those charities will get involved.
Thanks, Katie. The next question is for Pauline Heslop. Hi, Pauline. So this question is, I've sort of combined it because there are several around the same theme. So the bowel screening findings you presented are surprising and much higher than expected. Does the evidence give a sense of why the uptake of bowel screening is higher and why cervical is particularly low? And the second part, I think, that goes with it is, for bowel screening, there is the risk that carers, etc., may be carrying out the test for people with learning disability without their knowledge. Do you think that is possibly reflected in the figures?
Okay, thank you. So there's quite a lot in there to unpack as well, but I think in its most simple form, I mean, bowel cancer screening is obviously less invasive than breast or cervical cancer screening, and that might account for some of the distance. If a person is assessed as not having capacity to make the decision for themselves under the Mental Capacity Act, then decisions should be made in their best interests. And I really would struggle to think of many occasions when it wouldn't be in a person's best interest to have bowel cancer screening, but there may be more complex considerations to take into account with regards to cervical or breast cancer screening. And I think that may possibly be a reason for some of the difference. Now, we don't have research evidence that's based on a lot of anecdotal reports.
Thank you, Pauline, thanks for that. My final question is to Anne. So Anne, there's a lot of advice and information about the barriers to uptake, but where does the responsibility lie to implement these strategies? Local services often lack the capability and resource to do these things. How can NHSEI and PHE support local services to improve screening for people with learning disabilities?
I thought Southwark made a really good point, actually, which is that while there is a lot of information about barriers, there are relatively few things we know that work. And colleagues from Southwark made the point that even if we do know what works, sometimes the context or the arrangements differ or might be more appropriate. And so I think that clearly the local authority have got a duty to improve the health of their population, and NHS England are responsible for delivering services according to the service specifications, which include issues such as equity, uptake and coverage. So that's where the responsibility lies. So what I think PHE can do and is doing is stimulate research as much as possible. So we've got a network of people interested in inequalities, and we regularly try to develop research ideas or put research or involve academics. We've had an academic look at Facebook, for instance, or and we're just about to publish the latest systematic review on effective interventions to improve uptake without reducing inequalities. What the other thing I think we do is that when we're sure that something works, when the evidence suggests it does, we include it in the service specifications, and so that means that NHS England are required to deliver those, and then we have external quality assurance, and so we set standards. Public Health England sets standards, and we have external QA, and just to say that the QA activities have been slimmed down hugely because of COVID, but almost every single area that had a brief QA review mentioned inequalities and action to reduce inequalities in the way that they're setting the programmes up. We produce quite a lot of blogs and resources, and we need to make absolutely sure that they are useful, contemporaneous. Nick and his team do a huge amount of work with stakeholders and user groups, and we just need to make sure that that remains an active set of processes, and the blogs increasingly are able to be aimed at people with a particular interest. So if you're interested in learning disabilities or so, then you can actually start to flag the blogs. In relation to local authorities, it seems to me that when I've talked to local authorities about how to engage people in screening and inequalities, they have got such large agendas that somehow I think we need to work with local authorities to see whether we can make sure that the advice we give can be implemented alongside other activities. So if there are activities to improve exercise in particular communities, that might be a circumstance in which we could raise awareness about cervical screening, for instance. And I think if we can engage local authorities more in our networks and in our thinking, then I think we can start to tailor the activities, the research and the resources better to those better to local authorities so that the members understand, and it's easier to prioritise the activities as part of other pieces of work. So those are the things that I would suggest that we can do to help. Sorry,
thank you very much, Anne. So that ends the panel questions. So I'd just like to extend a big thank you to the panel for being so open to the questions. Thank you. Handing back over to you now, Anne.
Wonderful. Well, it just falls to me then to thank everybody for attending, for really powerful, engaging and high quality presentations. When you look at what actions you'll take away from today, there are tons and tons of them. It's been a fantastic day and a huge amount of engagement, and I want to say thank you to the presenters. They've obviously gone to a huge amount of trouble and thought, and also to everybody who's attended and contributed. It's a difficult enough time, and it's Friday afternoon, and COVID, etc. So that both says that this is a really interesting and engaging topic, but people have come and stayed and engaged, and I just want to say thank you very much indeed. I'd also like to say thank you to my team, who this is our first live Teams event. It's been easy for me. I've swanned in and said stuff when they've told me, but I know that it's been a huge amount of work, and the fact that we've got the questions, the videos, the presentations all smoothly done is a real testament to everybody's efforts. So thank you very much, and we will publish the questions and answers, and we'll publish all the resources that we've had at the conference. And if you want to know more, then get in touch with one another or go via us, and we'll put you in contact with one another or send you other pieces of resource or information that you might like. So thank you very much. I hope that you enjoy what's left of Friday, and you have a peaceful weekend. Thank you very much.